All right, I'm going to try to keep us on schedule. I know most of you here. I'm Laura Javsicas. I'm the internal medicine specialist at Rhinebeck Equine. I've just celebrated my 10-year anniversary at Rhinebeck Equine. Time flies when you're having fun, as they say. Oh wow, didn't need applause, but anyway, still excited for foaling season. So as everyone knows, I love babies, especially the sick ones. So today we're going to talk about foal colic and diarrhea. There's a lot of information to cover in a relatively short period of time. I probably have too many slides, but you probably all know that I also talk pretty fast. So we'll get started. So I tried to break this down to think about age predisposition for some different diseases, because it really does change pretty distinctly as our foals age. In the newborn, less than 2-day-old range, we can see enteritis, ileus, or enterocolitis, which we'll see across the board here, gastric ulcers, and then we have meconium impactions and strangulated inguinal hernias. When we're just a little bit older, so at that sort of 2 to 7 day mark, we can add uroabdomen from a ruptured bladder onto the list, as well as some of our congenital abnormalities, atresia coli and ani. And then as they get older, we have more variety. So we add gastroduodenal ulcer disease to our run-of-the-mill just gastric ulcers, as well as Lawsonia intracellularis, Ascarid impactions, small intestinal volvulus, intussusceptions, and strangulated hernias. So we're going to go through all of these problems, but first I just wanted to very briefly talk about the wonders of the equine GI tract, probably the most poorly designed system. This is representing the adult GI tract. And so in adult horses, and this is sort of a precursor to help us understand why we see some of the disease we see in our foals, and why it changes so much as they age. Because in the adult horse, our enzymatic, it's working, there we go. Our enzymatic digestion happens primarily here in the small intestine, and that's where the protein and virtually all the carbohydrate is digested. And then in the hind gut, the cecum and colon, there are massive quantities of bacteria, and microbial digestion occurs, and that's what breaks down fiber. And that's really important to the digestion in our adult horses. So in our foals, that large intestine really isn't functioning that way just yet. Foals have an underdeveloped cecum and colon. And so most of the digestion is happening in the small intestine. And so that's why their dietary needs are so different, much more low fiber, things that can be easily digested in the foregut, such as milk. And so as our foals age, what they're really doing is populating their large intestine with bacteria and fungus that helps them digest fiber going forward. The equine microbiome is an area of a lot of research right now, the GI microbiome in particular. Do not ask me to explain how any of this was done, but we're just going to look at the pretty colors, because the point I want to make is basically what I can tell you about this graph is that the closer the dots are to each other, the more similar in population those organisms are. So they basically take fecal samples from horses as they age and look at the diversity of the organisms in their colon. And what's really interesting is these are 1-day-old foals down here, 7-day-old foals. The blue is 28-day-old foals, orange 60, purple is a little hard to see. They're kind of mixed in here. That's weaning, and these are the mares on the day the foal was born. So as they age, their microbiome also ages and gets closer and closer to an adult horse. We know this is of tremendous importance, both to keep our mares healthy, to keep our foals healthy, probably to prevent some of these infectious kinds of diarrhea that I'm going to talk about later. What we really are very bad at right now is manipulating it in appropriate ways. So I'll mention probiotics, prebiotics later, but right now we know it's really important that they have a good balance. We're just not great at figuring out how to manipulate it in a positive way. We're really good at screwing it up. But just keep this in mind as those folds age, it's really their colon that's learning how to digest fiber in their diet. It's also pretty fascinating because when they did this study, they could actually see there's different slight variations from farm to farm based on what those horses are eating. So also important to think about that we want to keep our mares' diet and microbiome as healthy as we can, because that's going to be the source for those foals. Okay. So I'm first going to talk about colic, and then we're going to switch gears and talk about diarrhea, colitis in the second half. So some basic causes of colic. Some of you have probably seen this before, but I think it's really important to keep in mind because a lot of times someone will call and tell us that their foal is straining, and it is a good thing to be able to differentiate if they're trying to urinate or defecate. So when they're trying to defecate, such as with a meconium impaction, they tend to have their back arched like this versus posturing to urinate like this. So just a good reminder. Meconium impactions, really, really common cause of colic in those very young foals. As was mentioned at the beginning of the day, really important to take note of whether or not the foal has passed meconium and when they did that. These foals typically present straining to defecate. Colicky, they may have abdominal distension depending on how long it's been going on. In terms of diagnosis, we often do a digital rectal exam, see if we can feel a lot of meconium sitting in the rectum, and then ultrasound and radiographs are ultimately extremely helpful. So this is a radiograph of a foal with a meconium impaction. We can see some gas distension in the intestine here. This big gas cap is in the stomach. And then we can actually see the meconium within the pelvic canal. Ultrasound, what we see is this speckly, what we call heteroechoic appearance. I have another a video for you next, but this very sort of varied hyperechoic material. And often we have to look way up in the inguinal region with our ultrasound probe. Sometimes we will put the foal on the ground on their side to get a better look. And then we can also see this massive colonic distension. So as things progress and all the gas starts to back up, their intestine gets more and more distended, and their abdomen gets more and more distended externally. This is a video of a meconium impaction. So this is the small colon with the meconium in it. You can see how it has a sort of variable appearance to it. Treatment for these foals, I do typically put these foals on antibiotics. They're very susceptible to becoming septic, and anything that's going to inflame the intestine is going to make them more susceptible to a systemic infection. Nutrition, these foals are dependent on milk for glucose, on calories at that time. And so if they're colicky and things are backing up in their intestine, then sometimes we do need to keep them off the mare and prevent them from nursing for a short period of time. And in those cases, it is best if they're in a hospital situation so that we can provide them fluids with glucose while they're being held off the mare. That's also going to keep them hydrated at the same time. And then with all sick foals, we're always thinking about, do they have adequate passive transfer immunity? Is their IgG adequate? So all the routine nursing care things apply in these situations. I will give these foals Banamine. I always feel better if I can check their hydration and their kidney function. But your average, otherwise systemically healthy foal is going to tolerate 1 dose of Banamine quite well. I will typically pass a nasogastric tube to see if they have fluid backing up into their stomach. If they do not, then I will administer very small amounts of mineral oil and milk magnesia to help break up that impaction from the front end. And then enemas were mentioned this morning. I completely agree with Dr. Goslin. My rule of thumb is no more than 2 fleet enemas per foal. That's because the fleet enemas contain very large quantities of magnesium and phosphorus, and you can actually really mess up their electrolytes if you overdo it with a fleet enema. Soapy water enemas are very safe and can be a good sort of second step after fleet enema. But in a situation where we really have a colicky foal with a confirmed meconium impaction with our imaging, I am a huge fan of retention enemas, which we do with a compound called acetylcysteine, which actually helps break down the meconium. So if you take meconium and put it in acetylcysteine, it will dissolve it. And that's important to remember too, because when it resolves, you're not going to see meconium come out. You're going to see just paste. That means it's doing its job. So to do this, I typically sedate them. I will actually give them a very, very small dose of buscopan, which helps prevent them from straining against the catheter that we'll use. And I often give them a bolus of fluids while they're sedated and down, because that's an easy time to give a full bolus. So this picture is a little confusing from the angle, but this is what we do is we raise the foal's butt up in the air, and we pass a Foley catheter into the level of the hip here and clamp off the catheter so the fluid is retained within the rectum and small colon. And I try to keep them down with the catheter in for at least 15 to 20 minutes, depending on how feisty they are. And as I said, often this is we'll do fluids at the same time here. Reasons or times when I would become worried after treating a meconium impaction or during treatment is if they do start to have reflux, just a sign that things are really backing up and nothing's going through their system, and really need to think about fluids and calories in that case. Progressive abdominal distension. When we have hospital foals, we routinely measure their abdomen, just measuring tape. We clip little marks on them, and it's a great way to slightly more objectively tell if their abdomen is starting to become distended. If they're not responding to pain medication, and then if they have free fluid in their abdomen that starts to look like it has little flecks in it or it's hyperechoic, then we worry that they're starting to develop peritonitis, which can happen if that intestine becomes severely damaged and starts leaking. So this is what we want to avoid. This is the radiograph just showing gas everywhere, free in the abdomen, in fact. And then on ultrasound, this is the lung, the diaphragm is here, and then we could actually see a free gas shadow in the abdomen. So that is not, we want to get ahead of the game before we get to that point. I just wanted to mention, these are fortunately incredibly rare, but there's two congenital abnormalities that can trick you, because initially it may seem like a meconium impaction because they're straining to defecate. However, key thing is that in this case, there is no meconium, because what this means, the atresia means that there's the lack of an opening. And so this is a barium study. So the barium is put in through the rectum. This is atresia coli, which means that there's this blind-ended pouch to the colon. It's not connected. And in the case of atresia ani, just like it sounds, there's no opening to the rectum. These are not good problems. Unfortunately, they are really, really, really uncommon. But again, just to sort of a red flag, if they look like they have a meconium impaction, but you're not seeing any meconium at all, just keep it in mind. So uroperitoneum, or a ruptured bladder, this just means urine in the peritoneal cavity. This ultrasound picture on the left is actually incredibly rare to have. So we could actually see this very, very thin. This is the bladder right here. We can see this very, very thin spot on the wall. And this is all free urine within the abdomen. This is a foal with a very obvious round distended abdomen. When they have abdominal distension like this, it can be fluid. The fluid can be urine. It can be blood. This can also be gas distension, secondary to meconium impaction. So ultrasound is really our friend in these cases for helping to differentiate. These foals typically are straining to urinate, might be dribbling urine, and this is most common in that 2 to 7 day range. So usually doesn't become if it is a ruptured bladder, it usually ruptures at birth, more common in colts, but it often takes a few days for them to actually start showing any signs from it. So you may not see it right away. These foals often are not nursing well, have high heart rate, high respiratory rate, and it's not uncommon that they may have signs of systemic sepsis as well. One of the problems we have when we try to treat these foals is that they can develop severe electrolyte abnormalities. So their sodium and chloride go down, their potassium goes up. When their potassium gets really high, it can slow their heart rate down, and they become an anesthetic risk. And their azotemia is from their kidney values going way up because their urine is going into their peritoneum, and then what happens is it actually goes back into their bloodstream. Okay, this is just another video showing this is the bladder here, but then we can see all this free fluid here. And in this case, you might be saying, well, why does the bladder still look distended? Well, what we actually see, what I see more often than a true bladder rupture, is that the urachus, the area just inside the umbilicus, often starts leaking. And that is usually secondary to an infection of that structure. So they get an umbilical infection that is internal as well as external. And that tissue becomes so inflamed that they start leaking urine from that structure into their abdomen. And in those cases, the bladder can appear intact. The bladder still fills. It just is a slow leak out of the urachus. That's the bladder rupture. So in addition to the ultrasound and seeing that free fluid, the more definitive way that we diagnose these folds is that we take a sample of that fluid from their abdomen and we measure the creatinine, which is that kidney value that I mentioned, and we compare it to the blood. So if the fluid in the urine, the fluid in the abdomen has a creatinine that is double what it is in the blood, that confirms that it is in fact urine. When we take that sample, I will often do a culture because that fluid can be septic, particularly if it's that situation where it started with an umbilical infection and then started leaking. So treatment, this is a true surgical emergency. I'm not going to fix this. I need my surgeon friends. However, because of those electrolyte abnormalities, it often takes us a little while to get them stable enough and get those electrolytes fixed so that they can safely be anesthetized. In the meantime, they are getting broad spectrum antibiotics. I do a blood culture on them to check for sepsis, as we do with every sick foal. And then using some special fluid combinations to try to get them stable enough where they can be anesthetized. The prognosis is quite good if it's an uncomplicated bladder defect and even the umbilical infection. What happens is that entire umbilicus is just resected surgically and repaired. If they have other diseases, if they're septic, have failure passive transfer, other things going on, then that can decrease prognosis. Okay. Strangulating inguinal hernia. So this is actually a gypsy Vanner foal that we had in, I believe this was last year, that came in at about 16 hours of age. So this can happen pretty early on. And so they can have an inguinal hernia, and they can have, meaning a hole in their in the ring where their testicle is descended. But if the small intestine isn't stuck in that hole, it may not cause a problem. So you can have an inguinal hernia without colic and without it being strangulated, but once that intestine gets into the hole and gets distended, it can get stuck there. And so it's an important differentiation because it makes a difference in terms of when and if we're going to fix the problem. So in this case, you can see this very large distended scrotum here. I think Dr. James may have actually sent this case to me. And then on ultrasound, so this is taking the ultrasound probe right over this area of swelling, and these are all loops of distended small intestine in that scrotum there. And in this case, we were not able to reduce it, meaning we were not, even with the full anesthetized, we were not able to get the small intestine back through that hole. So this did become a surgical emergency. This is the cute little gypsy Vanner under general anesthesia being monitored here. And in this case, they were able to go in through the scrotum, reduce the hernia, and they did do a unilateral castration. So it's always a conversation with the owner because that testicle is going to be, has to go so that they can close the hole down and nothing goes back through the hole again. In some cases, they may go ahead and do a bilateral castration at the time. It depends on what the owner's desired feature is for the animal. Okay. Gastric ulcer. So these can happen at any age, from birth to death. But in neonatal foals, they're actually quite different than in other age groups. So it's been reported that the prevalence in foals is 25 to 57%. There are no studies on prevalence specific to critically ill neonatal foals. But what we do know is that the anatomic location and the cause of ulcers changes dramatically. So in our neonatal population, the sick foals that I see, they primarily get ulcers in what we call the glandular region of the stomach, because they have decreased blood flow and decreased perfusion to the stomach. It has absolutely nothing to do with acid. Whereas our older foals and our adult horses, when they have disease in the squamous portion of their stomach, that is caused by acid, the presence of acid in the stomach. So it's a totally different thing, and therefore our treatment needs to be different. And our primary treatment is supporting that foal, making sure their blood pressure is adequate, they're well hydrated, treating all their systemic disease so that their stomach is well perfused. Clinical signs can be, they are more likely to have diarrhea with ulcers in an adult horse, and that's because their GI tract is working completely differently, as we talked about at the beginning. They can act colicky. This is sort of the classic lying on their back position. It's thought that this might kind of relieve the pressure on their stomach and shift around all the fluid in their stomach. Bruxism is grinding their teeth and excessive salivation. So while the supportive care is the most important part, we will often also treat these foals with some antacids. I don't scope these foals as I scope adult horses practically every day. But these little guys, I'm not going to scope them unless I really, really need to, because it's a big scope. I don't want to sedate them if I don't have to. So that's part of the reason we don't know the prevalence as well, because it's not something we're just going to do for the heck of it. We do have some of these foals that have severe GI disease, might be refluxing. We can't give them oral medications. There is an IV proton pump inhibitor called pantoprazole that we can use in foals. Of course, quite expensive, but in some situations that can be helpful. So as these foals get older and we get to this weanling stage, we have this fun new syndrome that we call GDUD, or gastroduodenal ulcer disease. And this is quite different from the stomach ulcers that we see in adults or in neonates. So this is actually ulceration in the proximal duodenum, right where it leaves the stomach. And they often also have squamous and glandular lesions in their stomach, and their stomach is typically quite distended. Why this happens at this age, we still don't really know, but it is more common in foals that were sick, specifically that had diarrhea, and specifically rotavirus diarrhea, as babies. And they tend to be the ones that present with this as in the weanling age stage. So these foals typically are kind of poor doing foals, poor hair coat, ill thrifty, and then they can present because they're grinding their teeth excessively. They may have colic, they might be salivating excessively, and they may have some diarrhea. Their stomach does not empty normally, but it happens because of this inflammation in the proximal duodenum, and so they can end up with a stricture there, partial or complete, that doesn't allow food to go through their stomach. What happens is in adult horses with small intestinal colic, their stomach gets very distended. They are acutely, violently colicky. These foals are not that way because their stomach is distended very, very gradually over time. So they're much more tolerant of this gastric distension than in another scenario. So they can be a little bit sneaky. But when we scope them, we typically see horrific ulcers. And then the real definitive diagnosis is to do a barium study where we give them barium and we take radiographs and can see how long it takes it to exit the stomach. So this is a postmortem photo, which unfortunately is how many of them end up. And this right here, so the stomach is over here on the left. This is the duodenum over here. And this is showing the strictured area right here. So what can happen with these foals if they're not treated aggressively is that can become a complete stricture and their stomach can get so distended that it may rupture. They also very often have secondary liver disease because the bile duct empties into the duodenum right about here. And so when things aren't moving through, then the bacteria goes up into the liver. So there's two different ways we can approach these foals. We can try to treat them medically with antacids, prokinetics, keeping their stomach empty, so keeping them with a stomach tube in, fluids. They definitely need antibiotics and also IV nutrition, which is quite expensive because they're not going to be able to get the calories they need orally. With medical treatment, what's reported is about a 50% survival to discharge. And this is really only even an option if that stricture is just a partial stricture. There is surgical treatment, either a gastroduodenostomy or a gastrojejunostomy, which essentially involves rerouting the exit of the stomach to a different part of healthy small intestine. It is not a great surgery. They can have obstructions, they can have adhesions, they can have post-op ileus. What's reported in the papers is 50 to 70% long-term survival, but most of us feel that that's pretty optimistic. So it is certainly an option, and it would be my choice over medical treatment, but it's not a nice disease in any way, shape, or form. Small intestinal volvulus. So this tends to happen in the 2 to 4 month old foals, and this diagram here is just showing, so this is the mesentery. It's this sheet of tissue that attaches all the small intestine to the dorsal body wall, so just sort of below the spine here. And what happens is this intestine rotates on the mesentery. So it's literally like you just take the mesentery, you spin the intestine all around. The problem is that the blood supply is also in this mesentery. So as soon as that small intestine, the mesentery is twisted, then the blood supply is cut off to that intestine. These foals tend to be severely colicky, and they often get distended fairly quickly. And they may or may not actually have a lot of fluid back up into their stomach because so much of the small intestine is involved that there's not much to actually back up into the stomach because of where the twist is. This is just a picture showing the same thing, sort of from above looking down at the twisted mass of intestine. So again, ultrasound is really, really helpful in these cases. And what we see are these distended loops of small intestine that are not moving, an increased amount of free fluid. These walls are also starting to get thick. So the longer the blood supply is cut off to that intestine, the thicker the walls get, the more damage the tissue gets, the worse our prognosis is. So this is a really important one to be aware of, because this is a good reason not to wait on a colicky foal in that age range. Because if they have a surgical option and we can get them to surgery quickly, they can do well. But the longer that small intestine stays with no blood supply, the worse our prognosis is. This is a picture of a neutrophil, a white blood cell with bacteria inside it, to remind me to talk about the fact that sometimes when this intestine starts to get compromised, we also get secondary peritonitis or an infection in the peritoneum because of that damaged tissue. So this is just an intra-op picture. And so this shows that twisted mesentery perfectly. I mean, it's literally basically in a knot. And so what we do is try to untwist it, not we, my surgeon friends, untwist it. And then sit and watch it to see if the color comes back, if the motility comes back, and try to make an assessment of what the foal's prognosis is. Sometimes the answer is very clear and the intestine is very black after it's been going on for a long time. So there's shavings right here. So that should be it. This foal did not, unfortunately, even have a surgical option, but we did a postmortem exam and found that. So it was pretty dramatic. Okay, Ascarid impactions. So this is typically in our older foals, so starting to get into the weanling age. I could do an entire separate talk on worms, but this is what we want to avoid, right? So this is small intestine. This is one of my favorite videos of all time. Oops, you can't see it. Okay, so this is a thickened loop of small intestine, increased free fluid here. And these little bright guys, those are the Ascarids saying, hi, I'm here, I'm stuck. So we tend to see this in weanling age foals that have a high Ascarid worm burden. Classically, this happens after they're dewormed and those worms start to die. They get this big mass of dead ascarids in their small intestine, it can cause an obstruction. And so they start to colic because of the obstruction. So we try to treat these foals medically by keeping their stomach empty. They often have fluid backing up into their stomach, rehydrating them, antibiotics, anti-inflammatories, pain medication. I try really, really hard to treat these medically because that intestine is incredibly inflamed and really doesn't like to be handled. And there's a pretty high risk of adhesions or scar tissue forming if they do need to go to surgery. However, sometimes if they are in unrelenting pain, or we are suspicious of a volvulus forming, or an intussusception, which I'll get to in a second, which are both things that can happen when the motility of the intestine is disrupted, then sometimes we have no choice but to take them to surgery. This is just a great picture of, this was actually I believe this was a 7-month-old foal that I saw in the field for colic. And when we looked in the bucket of reflux, there are all these nice ascarids. That's why you should not put your mouth on the stomach too. So this is what we call a jejunal intussusception. So what an intussusception means is that the intestine, it doesn't have to be small, the intestine telescopes one piece inside of the other. And so this is a slightly more normal small piece of small intestine. This is a thickened loop, and then this has a loop within a loop. So we call this a target symbol. And I don't think that's a video. The next one's the video. There we go. So here's our double loop here, and this is the distended small intestine that's in front of that. So this essentially causes an obstruction. These typically also do need surgery. This happens because there's something wrong with the intestine to start with. So worms, diarrhea, some sort of inflammation that's making it sticky. And so it gets stuck inside itself as it's trying to contract and telescopes in like this. So prognosis with abdominal surgery. Now I want to point out the year here. This is an old paper. There's actually no more recent data. We have gotten a lot better, but just to say that we really try hard to avoid abdominal surgery in these foals because there are more anesthetic risks, as with any species. And their intestine does seem to, they do like to make adhesions a lot. But when there are those certain situations where if we can catch them early, their prognosis can be quite good and they can go on to normal athletic performance. Okay, we're going to switch gears and yep, I've got 10 minutes. Cool. Talk about all the causes of diarrhea. So just looking at age predisposition. So I broke these out a little bit further. And some of these will go across the board. So Clostridium perfringens, Clostridium difficile, we can see at any age. In our neonates and our older weanling age foals, we see rotavirus. The rotavirus tends to have 2 spikes, salmonella across the board. Rhodococcus, we start to see in that 1 to 4 month age group. I'll talk about Enterococcus durans, and septicemia alone can also cause some diarrhea. And then weanlings, we get into Lawsonia, which I'll talk about. Okay, so enteritis in general just means inflammation. So specifically, enteritis is more of the small intestine. This is classic thick loops of small intestine not moving well, but they're not those big round distended loops like we saw with the volvulus. These foals often have decreased nursing activity. They may have diarrhea, fever, low white blood cell count. Now I'm going fast. So this is another ultrasound. Sometimes we'll actually see some gas. This bright white is gas in the wall of the intestine. That always makes me suspicious of Clostridium. With colitis, we tend to see fluid in the colon. So all this is diarrhea waiting to happen. General treatment for enterocolitis. So the entero is small, colitis is the large intestine. Broad spectrum antibiotics. We want to prevent sepsis. Again, the inflamed intestine, bacteria goes across the wall and can make these foals septic. Gastroprotectants, antidiarrheal agents. Pepto-Bismol, Biosponge. There's nothing new. Very small amounts of Banamine. We just have to be judicious and watch their kidney values. Fluids, huge fan of plasma. Probiotics, as I mentioned, really someday we'll be there maybe, but right now we really don't know how to manipulate that bacterial balance, but it makes us feel better when we give it to them. And nutritional support, these foals are really dependent on milk. So I'm just going to go through a few of these specific causes. Clostridium perfringens happen very early in the 24 to 5-day-old group. These foals are typically not nursing, have fevers. Classically, they have yellow, very distinctly malodorous diarrhea, and this can progress to hemorrhagic diarrhea. So when I see this, I'm most suspicious of Clostridium perfringens until proven otherwise. And one of the big issues with foals with this pathogen is that they can get dramatic gas distension and colic also. And so this can masquerade as primary colic, and so we have to really use our ultrasound, our blood work, other things to make us convinced that it's more of an infectious problem than another cause of colic. And they can actually get so bloated before they even pass any diarrhea. And that's, in some ways, that's kind of the problem. It's like everything just shuts down and they get this massive distension before having diarrhea. This is highly contagious. Diagnosis primarily these days is through PCR. It is really important to identify which toxins are involved. There's a bunch of different toxins, and that can make me more or less convinced about whether or not that Clostridium is truly causing our problem or if we have something else going on, but that's a bit academic. Antibiotics, so specifically to target Clostridium, metronidazole and penicillin or ampicillin are our friends, and then supportive care to try to get them through this. C. diff can happen with any age. This one's a little bit different because it's 10% of healthy horses shed C. diff after hospitalization or antibiotics. When we have antibiotic-induced colitis, which is more common in older horses once they've established those microbiomes in their colon that I was talking about, then we mess them up with antibiotics. So often antibiotic-induced colitis is the result of a C. diff population exploding in their colon. These foals are typically not quite as sick as those with C. perf, and it's not quite as contagious, but still is contagious. Again, diagnosis is with PCR. Treatment is the same, but we don't see that hemorrhagic diarrhea and the amount of abdominal distension like we do with C. perf. So salmonella, Dr. Taima mentioned this already. This is not, and not that we want any of these, but salmonella is highly contagious. It's also zoonotic, so you have to be really cognizant of you and your staff. Foals are most often affected in 12 hours to 4 months of age, but this can affect horses of any age. They often have fevers, depression, dehydration. This is typically brown-green diarrhea. Secondary issues are really common. So septicemia, joint ill, uveitis are all red flags that we might be dealing with salmonella. So testing is based on PCR. Culture is also really important with salmonella because that is what's going to tell us which antibiotics it's susceptible to. So PCR is really, really sensitive. Sometimes it's too sensitive because it can pick up very small amounts of the DNA of the salmonella, and the salmonella may be there and not actually be causing the problem. Whereas if they are culture positive, then we know that we have an issue. And that can help us guide treatment. So treatment should be based on culture and sensitivity, but typically we're reaching for our aminoglycosides like amikacin. In this case, it's a gram-negative organism. So Enterococcus durians, I just wanted to mention briefly because this is kind of a new emerging disease to be aware of. And it's a bacterial infection that has been associated with farm outbreaks, typically seen in 2 to 10-day-old foals. And it can be isolated from blood, joints, and umbilical infections. Fortunately, these foals are not terribly sick, and it may be a co-infection in some cases. Testing is with culture and PCR. However, there's only very select labs right now that are looking for this or testing for it all. There's only one lab that has a PCR that I'm aware of. So where we're sending our samples makes a really big difference. And when I'm speaking to veterinarians, I always really harp on that because you really have to make sure you know what you're testing for and what your lab may not be looking for. So I would start to think about this if I had multiple cases of diarrhea on a farm and we weren't getting an answer with our routine diagnostics. Fortunately, they tend to not be as sick as the C. perf and salmonella foals, but it can cause significant morbidity. This organism is susceptible to penicillin and ampicillin. Okay, I'm going to spend a little bit more time on rotavirus because there's some new things to talk about. So rotavirus in general is this nice, pretty little virus here. And one of the big reasons it is such a problem is that it's what we call a non-enveloped virus. So some viruses have an envelope around them, and that makes them easier to kill with disinfectants. If there's no envelope, they tend to be hardier viruses that are harder to kill. And what rotavirus does is it attacks these cells. This is the what we call the villi in the small intestine. And the cells on the tip of the villi contain all those enzymes that I mentioned at the beginning that digest carbohydrates for these animals. And the rotavirus attacks those cells selectively and destroys them. And so these foals have severe malabsorptive diarrhea, and then that whole carbohydrate load is going on to their colon, and they have what we call secretory diarrhea as well. So that is why this infection can be so severe, because it destroys all those enzymes they use to digest their food. So we now have two types of rotavirus. One wasn't enough. So rotavirus A is what we've all kind of known for a very long time. Very common, highly contagious cause of diarrhea in foals. And again, this has those two peaks, less than 1 month and then 4 to 6 months of age. The neonates often require more supportive care. Decreased nursing, rapid dehydration is common. And then older foals may require minimal intervention. They might still just be eating and bright and really require not much. They just have diarrhea. This diarrhea is typically gray or pale, another distinct odor. I wish I had like scratch and sniff rotavirus, just kidding. So treatment, supportive care, there's no specific treatment for the viral infection. It's all supportive care, fluids. The neonates, I definitely still put on broad spectrum antibiotics because of that risk of translocation of other bacteria through their intestine. But the one I really wanted to mention is rotavirus B. This is the novel strain that was identified in central Kentucky in 2021, just when we needed another infectious disease to worry about. This is not contained in the vaccine that we vaccinate mares with. So and unfortunately, there really doesn't seem to be much cross protection between the vaccine for rotavirus A against rotavirus B. This clinically is very similar to A. Severe diarrhea, 1 to 4 day old foals. They were seeing morbidity up to 100% on farms. So that means that all the foals on the farm were infected, all had diarrhea. Kind of a nightmare. Again, only a few labs are testing for this. So now there's 3 that I'm aware of. Maybe there will be more this year, but you still have to make sure that they're actually looking for what you're worried about. So rotavirus has really unique biosecurity challenges. Because of that lack of an envelope, as I mentioned, it's resistant to many disinfectants. There's also a huge number of particles shed. So there's 100 billion particles of rotavirus per gram of feces, which is pretty astounding. And they can shed for up to 3 days after the diarrhea resolves. So just because they don't have diarrhea, it doesn't mean you're out of the woods. It's also highly contagious, meaning that you only need a very small number of particles to infect another foal. And the particles survive in the environment for up to 9 months. So contaminated bedding and manure are a risk, and it's a reason to avoid spreading manure. Overcrowding is also a risk, as with any infectious disease. Just to mention, so knock on everything. As far as I'm aware, we haven't had a lot of cases of this yet in New York. Maybe this will be our year. But I did, sorry, you can throw things at me. But I did diagnose this in a foal last year. It was actually an older foal who also had C-perf. So foal did fine, probably because it was older. But I think we all need to be very much on the lookout for this. Lawsonia. So this is another disease that is endemic in many farms in Kentucky, more sporadic here, but again, really important to be aware of. This affects 4 to 12-month-old foals. This disease was first identified in pigs. It also happens in weanling age pigs. Not quite sure. It probably has to do with that shift in the way the GI tract works, but no one quite knows why is this age group specifically. But we see it in the fall and winter because of when our foals are that age. This causes what we call proliferative enteropathy, which means that we get thickening of the small intestine and they lose a lot of protein through their GI tract. Clinical signs are pretty variable. They can be depressed, they can have colic, diarrhea, weight loss, anorexia. They might have a fever, they might not. And edema is a really classic sign. And usually what we'll see first is just mild throat latch edema. So it's a good thing to look at when you're checking your foals daily and taking their temperature daily. Just maybe run your hand under their jaw because that's where you'll notice it first. Their white blood cell count can be high, low, or normal. But with a classic thing that we see on blood work is that their protein is really low because of all that protein loss. They also may be ill-thrifty, poor hair coat, pot-bellied, etc. And so what we see is this on ultrasound is this sort of pathognomonic thickening of the small intestine. This is 1 centimeter thick. It should be 3 millimeters, 0.3 centimeters thick. So really dramatic thickening. They're not all that dramatic. This is one I had this fall. But you can see, so there's a distinct loop here with a thick wall. Here's another thick wall here. Here's a loop with a thick wall. This was 0.35 to 0.5 centimeters. So diagnosis, PCR on the feces. There's also a blood test for it. And they may be positive on one or the other, depending on what stage of the disease they're in. For treatment, you typically start with the oral tetracycline, so doxycycline or minocycline. The macrolides that we use for Rotavirus can also be effective, and I should actually have chloramphenicol on this list that we'll use in some cases as well. These foals often need a lot of plasma. It's not uncommon for them to come in with a protein of around 2, so half of what it should be. And nutrition is really key because they are not able to digest their food and absorb their food because of all that inflammation in their intestine. So I really want to harp on prevention, and I really think it's worth thinking about. That foal I showed you an ultrasound of from a few slides ago from this fall was the only case on the farm. They have about 30 foals per year, and most things for most of us are going to be a cost benefit analysis. That one foal had a hospital bill over $10,000 and it's still not doing well. So it's, even if it's one foal, it can be a huge cost to try to save them. And we also now see cases that have, they get necrotizing enteritis with this and get really sick and are very hard to save. So sometimes it can be a very mild sort of self-limiting disease, but sometimes they can get very sick from it. And for many years now, there has been, so this is a pig vaccine. It's a modified live vaccine that we administer intrarectally. And the initial studies what's been recommended is 2 doses, 1 month apart, starting in July. So basically a dose in July, dose in August, in preparation for the time of year when they're typically affected. There hopefully is going to be a paper coming out soon, but anecdotally, there is a study that was done in Europe suggesting that 1 dose may be just as effective, which would be really nice. It's about $75 to $100 per dose. So it's not the cheapest vaccine out there. But again, if you've got your one valuable foal, it's not a great disease to have. So it'd be better if we can get ahead of it. Oh, I'm already over. Okay. This slide is just to remind me to say, I get a lot of questions. I just had the conversation this morning with someone about why should I pay for a diarrhea panel? Because when we do PCR diarrhea panels, it's actually, you get a lot of bang for your buck because you test for all these diseases, everything that can cause an infection, GI infection in a foal all at once, but they're expensive, like in the $300 to $400 range. But from a farm standpoint, it is really, really valuable to know what you're dealing with and how concerned you need to be, how rigorous with biosecurity you really need to be. Because if it's rotavirus, like, we need to burn down the barn. Exactly. We need to be on it, you know, to try to prevent it from getting out of hand, especially if you have a lot of foals. Obviously, if, you know, if in a situation where there's only a few foals on the farm, it may be different. But I really think it's worth spending the money so we know what you're dealing with. Certainly for the individual foal, a lot of times they're better or not by the time we have results, but at least I know what to recommend for then going forward for the rest of the farm. And sometimes it does also dictate how long we treat them with antibiotics. For example, with the clostridial diseases, I'll often keep them on metronidazole for 2 weeks once we have a diagnosis. So biosecurity could also easily be another whole talk. Just a few really key points. Cleaning and disinfection is key. Organic material is not your friend. So another tidbit, adult horses produce 50 pounds of organic material per day. That's a lot. Reducing organic material reduces your pathogen load by up to 90%. So it can make a huge difference. Think about what your barns are made of. Dirt and wood is not easy to clean. Overcrowding, also not your friend for any infectious disease. I do not expect you to be able to read this. Just to point out, we have a lot of disinfection agents. They're all very different. We have some new things available, and I am a huge fan. This category here, the peroxygen compounds, we use Rescue extensively in the hospital. It's hydrogen peroxide based. It's much nicer for your barn, your shoes, your foot mats. It works well in the face of organic debris. These little checks down here, so it's bactericidal, virucidal, fungicidal, kills tuberculosis. We don't really care about that, but sporicidal. So that means it also kills Clostridium spores. If you're using bleach, just stop, please. It's not doing anything. Bleach is great in a metal container with no poop in it, but it's not going to work when there's organic debris there. So, and these are really, they're much better for the environment. It's much less harsh. So I'm a huge fan, not paid anything by those companies, just FYI. So just a few things to think about, things to minimize: foot traffic in the barn, visitors in the foaling barn. I know everyone wants to come see their cute babies, but think about what they're spreading around. Leaf blowers, you can be blowing all of those pathogens all around, and pressure washing the barn when it's occupied. So you may just be aerosolizing infectious particles. Things to consider: using personal protective equipment, gloves, foot baths, dedicated staff, dedicated tools, meaning pitchforks, shovels, etc. Vacuum machines can be great for cleaning without aerosolizing all the debris. It's my last slide, when to refer. Right away, yeah. So colic, I think if they have severe signs of pain, they're bloated, fever, diarrhea, refer. Diarrhea, it's really dependent on people's availability to treat on the farm. Some of you out here have great staff, can certainly handle running fluids occasionally, but there's a lot of things we can monitor in the hospital setting that can play a huge difference. Their electrolytes, their acid-base status, all these things. If they're less than 1 week of age, they're going to be much more susceptible to septicemia. And then I also put in if they're dull and not nursing after a few days and they've had fluids and antidiarrheal meds. So in other words, they go from bright nursing and then all of a sudden they're like really, really dull, don't want to nurse, down in the dumps. Often what's happened in this case is that they're really acidemic because they've depleted their bicarb stores, which is something we cannot tell without running a blood gas. Is a blood sample that has to be run right away. So just a red flag to me. I always say, okay, can you bring the foal in, or can you bring me blood that I can run in 30 minutes? And then if they have diarrhea and colic, I definitely don't like that combination. That's it. That's my email. It took me 10 years to figure out that I could have an alias that's just Laura at Rhinebeck Equine, so you don't have to spell my last name. You're welcome. Does anyone have any questions? Yes.
run your hands under the jaw.
Oh,
I didn't understand.
sure.
What that was.
Yeah, so the question was about with Lawsonia, running your hand under the jaw. So they often, if they have edema, fluid in their soft tissue, it often starts in the throat latch region. So and a lot of times, especially if they've got a lot of hair there, you can't see it. So if you just run your hand under their jaw, right at the throat latch of the halter, you may feel edema there. It may be squishy, it feels swollen and squishy. That's a great question. So the question was from a foals building their healthy microbiome standpoint, if it's better for them to be born later in the year, so they're outside more instead of being in a stall. I'm not aware that anyone's looked at that yet. They have looked at the mare's diet, and it definitely does influence the foal, which makes sense, right? Because I mean, they're literally, it's normal for them. Coprophagy is when they eat the foal's manure is completely normal. That's how they're populating their intestines. So that's why thinking about having your mares on a good diet is, you know, is really important. But I don't think we know. Right. I would, so from a hay versus grass standpoint, that may prove to be important, but what we know makes a huge difference is more grain versus is bad. Hay, forage should be the staple of all of our horses' diet, whether it's hay or grass. High amounts of grain, specifically carbohydrates, it definitely shifts the adult horse microbiome and changes that bacterial balance. Yeah.